I'd like to welcome Patrick J. Kennedy, co-author of Profiles in Mental Health Courage, former congressman, and co-founder of the Kennedy Forum, a nonprofit that has achieved and continues to seek transformative shifts in mental health and substance use disorder prevention, treatment, and care from both an implementation and policy perspective. Thank you so much for joining me on the Dr. Suzette Glassner podcast today.
Thanks so much, Suzette, and thanks for dedicating your life to this cause of addiction treatment and increasing the knowledge and understanding of this as a disease and not a moral failing.
Likewise, I'm really excited to talk to you today about the great work you're doing at the Kennedy Forum, as well as your recently released book, Profiles in Mental Health Courage, which I have to say I really enjoyed reading. One of the things I really appreciated about your book was the authenticity with which not just the existence of mental health struggles, but the nature of those struggles and the way that the 12 individuals who were really profiled in your book, the way that they sort of painted a picture of what it's like to progress through a mental illness and also to find their way to a better future. The fact that we have evidence-based practices that are highly effective, but it is often challenging to access them, not only in terms of being able to find the correct type of treatment and to facilitate that kind of access to what it is that we know to be effective, but also some of the psychological struggles that a person can go through in the process of even coming to terms with the fact that they have a mental health diagnosis and some of the steps that they need to take in that direction to get well. One of my important takeaways from your book was that through telling stories and being more open about one's struggles with mental health, we really kind of chip away at stigma and misunderstanding. And just to open up, I wanted to ask you sort of what's your perspective on the importance of chipping away at stigma and misunderstanding to facilitate access to help that people need?
Well, to draw an analogy to the civil rights movement, we haven't gotten rid of systemic racism by a long shot, but we've passed laws to end discrimination, housing, employment, transportation, so forth. And we need to do the same in mental health. I frankly think we end up furthering stigma the more we frame this as stigma rather than discrimination. Because point of fact, to your very observation, we treat these illnesses separate and unequal to the rest of physical health care, even though we know, and you've made your career understanding these are brain illnesses. We have all the data, we have the science, we have the genomics. These are the most heritable illnesses out there. We know that they're not a reflection on people's personal will. I mean, who would get up in any given day and try to, upset their family, jeopardize their lives, jeopardize their freedom? The people's illness takes their brain and their lives hostage. Anyway, so my point is that the understanding I saw with this book is, as you point out, a general understanding of what it's like to actually live with these illnesses. Now, most of the stories people read are advocacy stories where people kind of self-edit and have a happy ever after story. That's not the reality. The reality is these are chronic illnesses, ups and downs. They involve family. That piece of the story is never told. Like, how do people negotiate family relationships? How do they negotiate work relationships? That's what I was interested in doing with these 12 stories. These are not individual stories per se. They're stories of people, and I interview the families of each of these people. So the transparency is validated in the sense that it's not just the remembered part of the story of the person. We talk to their treating psychiatrists, we talk to their family, even talking to people that they don't talk to anymore. And that's where their real courage comes in, because they really open themselves up. And I think that gives everybody a sense that they're less alone when they read these stories, because I think when you read a whitewashed story in the general public, you have a sense that you're just not good enough or you're not hacking it. Whereas if you read these stories, you say, listen, I'm not in an uncommon struggle here, because that's the common theme. No matter what the diagnoses, some of the pitfalls and challenges are all kind of common. And of course, insurance reimbursement and access to quality care. So not just getting payment, but payment for treatment that works. Those are our big goals in our mental health advocacy world. But I didn't want to hit this as an advocacy book because people wouldn't be interested in it. At the back of the book, I have my advocacy pitch through a QR code and URL for people to log on to what we should be advocating for. But that's not what I embed in the stories. However, when you read the stories, it's pretty clear to people where the big barriers are in the system.
Absolutely. I wanted to hone in on a couple of the stories that jumped out at me. I mean, they all did in different ways. And I think you're hitting on one of them in a way already, which was Henry's story. And Henry was at Penn struggling with depression. And there was mention of this concept of pen face. And I think some of what you were describing just now, as far as you don't know what's behind a face. So many people are suffering their family dynamics, their jobs, their ability to function day to day. And you can't really read that well on their face and the way that they're moving through day to day life. And my understanding, but you could correct me if I'm wrong, about what pen face really means is that sort of stoic and very present in our society kind of impression management that we do of people, particularly through social media, of like, everything's perfect in my life. Here are my best moments. This is my best face. But underneath, there can be a lot of unspoken suffering and struggle. And it's that unspoken suffering that often leads people to adverse outcomes like suicide or just even poor clinical course of their illness. So my perception is that one of the kind of targets of not only your book, but also the Kennedy Forum is really to try to do away with pen face that's not unique to University of Pennsylvania students, but really permeates our society. Do you think when it comes to mental health, we've made headway in that direction since you've written this book, or not so much?
Well, I think this new generation is obviously the other angle in that story is much more open to talking about their struggles, much more so than a previous generation. That's a big positive. It's also putting a big pressure on employers and their third party administrators, their insurance companies, to be much more proactive in how they offer benefits that are comprehensive, which I think will really help change this whole space. Because the more you normalize mental health being part of your checkup, being part of your cardiovascular disease, because if you can't treat depression, rates of heart attack are 4 times higher for people with underlying depression. You can't treat oncology because if you got cancer, you know, to deal with the trauma of that, the anxiety, depression, you're not going to be as compliant. The outcomes aren't going to be as great. We know all this, but just generally speaking, there's a lot of illiteracy in the whole healthcare space because unlike what you're doing in educating psychiatrists, in the general field of medicine, there's really not a whole lot of emphasis. There's a few places that are doing more to emphasize and integrate mental health education into overall healthcare professional development, but that's still a far cry from where it needs to be. But the pen face thing, I mean, I found it when I was in Congress. I was the only one any of my colleagues knew that was an alcoholic because I was all over the headlines. When I came back from treatment, the number of my colleagues that I had no idea were also fellow strugglers. They opened up to me because I was the only one I realized that they knew. And then I realized if I wish that all of them had known each other, because then they wouldn't have felt so all alone. And I mean, I'm talking dozens and dozens of colleagues, obviously bipartisan, because these don't know any partisan differences. So I would say that obviously the social media phenomenon now with technology so ubiquitous, you know, people don't have the resilience because they're just not engaging kind of face to face, if you will, that they're able to have the quote face social media versus the reality of life. So yeah, I think the other part of the pen facing is we don't share, right? So the point of my cousin Mark's story with his son Harry is that when I interviewed Mark and then Harry took his life, for those who haven't read the story. And then I interviewed Harry's roommate in college. And then I interviewed Harry's brother. What was the narrative from that is Harry's brother never told his father what he saw. Harry's roommate in college never told Mark what he saw. Mark never told Belton. So my point is, if they had all been able to share more transparently, you don't know whether you could have changed the trajectory of Harry's ultimate suicide, but I guarantee you would have responded to it with a lot more urgency had there been a fuller picture. And I think that's a narrative for all of us One, we all try to minimize because that's just our natural inclination. And we don't want to feel like we're talking about people out of school. But this wouldn't be so, quote, personal if we looked at it less as a personal issue, as a medical issue, which is what it is. And that's the big barrier we still face as a society. We still think these are matters of personality because they manifest themselves in personal behaviors, when in fact, those are physical manifestations of the disease of addiction and mental illness.
I couldn't agree with you more. And I think part of sort of the extension of after learning a little bit about Henry's background and his story, one of the themes that I think was sort of woven throughout the book is that generally positive things start to happen when people open up. So for Henry, he actually developed a really meaningful relationship with Hannah, and that stemmed from him opening up about his vulnerability and about his mental health. And of course, you can't realistically expect that everyone's going to be a Hannah and respond in the same way. But even your experience after being all over the headlines in regards to your alcoholism, of other people approaching you and sort of opening up, that's similar to what happens for other individuals in profiles of mental health courage, and also more broadly from my own clinical experience. So one of my questions is how do you think society and policy around mental health change would shift if more people were courageous in that way?
Well, we are the biggest special interest group in this country that isn't heard on Capitol Hill. I mean, not heard at all. And that's because, as in the case my wife just ran 4 years ago, I should have had every list there was of anybody, any family that had lost a loved one to suicide, to overdose, depression, bipolar, Mental Health America, NAMI. I know every one of them. And I know all the leaders of the psychiatrists, the psychologists, the social workers. But the bottom line is when she was running for office, I could get 100 bricklayers the day after tomorrow to show up anywhere for my wife. I could get, as we did in the end of the campaign, 5,000 public school teachers all over my wife's congressional district to show up anywhere I needed them. I couldn't get 10 mental health professionals because I don't know where the psychiatrist lists, the psychologist list, the social workers list. NAMI has got lists, and DBSA, but why is it so hard to get a universal list? Now, if you are running for office, the AFL-CIO has truck drivers, road pavers, municipal clerks, nurses, everybody's on the list. Iron workers, sheet metal workers, carpenters, they're all on the same list. If you look at the environment, League of Conservation Voters, they have the air quality, the water quality, the land. I mean, they have got it all. It's one-stop shopping for advocacy. Our space is so siloed. And we also have not developed the sophistication of other advocacy groups to cull together that unified vision and then execute on it so that we can hold public officials accountable to whether they vote the way we want them to vote, whether they budget the dollars we need to have budgeted towards neuroscience, towards prevention, towards a public health model, which frankly is the only way we're going to get out of this major tsunami of mental illness and addiction, is that we take a public health approach, because we cannot treat our way out of this public health nightmare we're in.
Yeah, there's so many levels at which we need prevention, intervention, quality care, and then obviously the issues surrounding reimbursement and access. But I agree that we can't treat our way out of it. And we do know that for at least half of the individuals who end up with a substance use disorder in their lifetime do so when they're in their teens, before the age of 14. And I've heard you speak about this, about prevention, about the fact that we tend to wait until a substance use disorder and or a mental health issue is so severe that the person is in crisis and they've progressed really far along that trajectory. It doesn't mean that there's no turning back, there's no effective management of it, but what if we could catch it earlier? So there is this concept, and I know you're familiar with all these individuals, that George Koob, director of the National Institute on Alcohol Abuse and Alcoholism, Nora Volkov, director of the National Institute on Drug Abuse, Tom McClellan, former deputy director of the Office of National Drug Control Policy, they got together and they wrote about this concept of pre-addiction, we hear about pre-diabetes all the time. You just go to the doctor for a checkup and they say, "Ooh, your A1C is looking a little concerning. You might want to think about weight management, et cetera, et cetera." But we don't do that despite the fact that we have really robust knowledge of the risk factors for substance use disorders and mental health issues. I'm curious what you think about this concept of pre-addiction and whether that figures into some of your work at the Kennedy Forum.
So at the Kennedy Forum, we've put together the first policy guide ever for members of Congress. It's kind of shocking that it doesn't exist, that we have each disease group have its own policies. All of them never work together in conjunction with other similar priorities for other disease advocacy groups. But so that's why I said we need the policy, then we need to pick, as other interest groups do, our top priorities, and we need to pursue them. And we need a global vision. So our vision, in my view, should be within the next 10 years, 90% of Americans are screened. To your point, we screen for cancer. We screen for cardiovascular. We screen for diabetes. We don't screen. We wait, as I said, till stage 4. And then we wonder why these illnesses don't get better. I mean, tell me a cancer that gets better if you wait till stage 4. Then we need, so 90% screen, 90% given evidence-based treatments. Now, that doesn't sound like any controversial concept. Of course they should be, but that's a huge lift and reach when you consider that over half of the clinicians in this country are not trained in the evidence-based treatments of the diagnoses that they treat. That's pretty astounding. Frankly, not a surprise since we've never paid for mental illness and addiction. So we don't have that kind of back room helping to bring the standards up that we need. And then 90% of Americans able to manage their illnesses in recovery. So that means we have to really address the social drivers because those really can trigger, exacerbate, and impede full recovery. So that should be our 90, 90, 90 by 2033 is our goal. We have gotten every one of the advocacy groups to sign off on that, which is a real start. Now we got to put things together to build that cohesive, as I said, AFL-CIO or League of Conservation Voters to go after this. So I can guarantee you we change things tomorrow if I could hand any prospective candidate for office a list of everyone in their congressional or state reps district that cares about these issues. They would be like bending over backwards to say, I'll put the money in for neuroscience, I'll put it in for prevention, I'll integrate social emotional learning in the schools to empower our kids to have better stress management, coping mechanism development. I'll put in money for recovery supports, which aren't covered under healthcare. I'll blast out the recovery community organizations, the clubhouse models, the supportive living. We need sober housing. The notion that insurance companies pay for these repeat hospitalizations for addiction, but don't pay for long-term sober housing, which, by the way, is a lot less expensive when you consider all the relapses and a lot more effective in terms of both the people's recovery and the costs on the system. So bottom line is I'm really happy to have had this chance to visit with you and hope your listeners, if they need to know more, we're building a modern day apparatus to advance these issues because that's what we need. And ultimately, financing is the key to all of it. So I'm not just talking about paying. I'm talking about having the results dictate whether you get paid. So instead of paying for services, we got to pay for outcomes. If we're paying for people to be stable in their communities, managing their illnesses, guess what? We'd be paying for a lot of other things than just meds and beds. We would be paying for supportive living services, psychosocial supports and everything. And that's where we need to go. And we need longer term ROI. So we need to come up with a new system of reimbursement that shows the value of those early interventions. And I think we can do that if we engage the insurance companies in order to do that. And people would listen to this and say, how in the world are you going to do that? Well, thanks to the Biden administration, we just had a rule release this last week that really puts a lot of pressure on the payers to comply with the federal law, which I was honored to be a co-sponsor of. And that, I think, will bring them to the table. And because it gives us leverage to say to the insurance companies, okay, you don't have sufficient in-network capacity. Let us help you pay for what we want. And then we're not going to be jumping down your throats. I mean, it's an age-old power concedes nothing without demand. We have a demand now. We have the power as consumers, but we have to utilize it in order to get what we want.
Absolutely. And I think nothing speaks louder than the potential for cost savings and cost effectiveness. It's not very well understood. I think the general sense of care for substance use disorders in particular is just it's very expensive and it doesn't work. And if you are actually accessing evidence-based treatment, it's highly effective. It's highly efficacious. We know that. And to the extent that it reduces hospitalizations, it improves overall physical health, as you mentioned earlier. Substance use disorders and mental health are really inextricably linked with a number of overlapping chronic conditions. Rarely do you see somebody with just a mental health or just a substance use disorder condition. And those are the drivers of cost. So when you get somebody to manage their mental health effectively, a lot of risk factors start to dissipate.
We are trying to convene the big employers. So the Fortune 500 companies, they have such a stake in this in terms of the benefit that comes from good mental health on the workforce, not just on the healthcare side, but on the productivity and absenteeism and workers' comp side. Then we need government, age, and state, principally counties, which have huge criminal justice spends, foster care spends, human and social services spends. We need them to put money. So at the end of the day, if we get the funding invested, so kind of like a social impact bond, we can invest in those things that have the best evidence outcomes. But if we don't have information technology, because 90% of behavioral providers are not in any EMR, how are we going to measure outcomes? So we need to strategically advocate for those things that on a system basis will change the whole direction of the Titanic, not shift the chairs on the Titanic, which is kind of what we've been doing for years. So the Kennedy Forum named it for President Kennedy was the president who signed the Community Mental Health Act. We launched this on the anniversary of the Community Mental Health Act. And I really think President Kennedy's vision of a community-based system should be the inspiring part of what we need to do. So it's not about psychiatry, although we need more psychiatrists, hospitals, although we need more beds, pharmaceuticals, we need better interventions. It's about community, because unless we involve housing, unless we involve supportive employment, unless we involve education and prevention, we're never going to get a handle on this. And we don't have that strategic vision. That's what the Kennedy Forum's trying to push. And we're very active in trying to set up a strategic office within the White House that will be required to organize how all of the agencies in the government should be part of a solution, because they each are tasked with helping to meet a strategic end. We call it our alignment for progress, because you have to align everything if you're going to make progress. I encourage people, if they get the book, you'll see the QR code, or if you could just Google Kennedy Forum or Alignment for Progress, you'll find out more about what we're doing. But really appreciate this opportunity to be with you.
Thank you so much for joining me today. Patrick J. Kennedy on his new book, Profiles in Mental Health Courage. Thank you, and we'll see you next time.